Very clear. We are in October month. It's the awareness month of breast cancer. We talk about it every year. So very important that we try to raise the awareness in all aspects regarding breast cancer. You probably all know that it is the most common cancer in female in Saudi Arabia and worldwide. We know that 1 in 8 women will develop definitely breast cancer during their lifetime. And this is really based um, on real statistics worldwide and in Saudi Arabia as well. Um, because of the high incidence of breast cancer in our population, screening is extremely important. And as we all know that the best way and the only way that has proven to be useful in detection of breast cancer is mammography. We know that mammography definitely increase the early detection rate of breast cancer, and that would result in significant drop in mortality. And this is what makes mammography is a very successful tool for screening, because it has been proven that there is significant drop in mortality rate because of the screening, without forgetting that the mortality rate has dropped as well because of better treatment and awareness. So we know that the percent of reduction in mortality is ranging between 22% to 64%, depending on the age or the population of the age that is being screened. However, we know that it's reaching up to 64% in the reduction in mortality rate. Something that's very important to keep in mind is whenever we are talking about an exam for screening, we always have to think about a multidisciplinary approach, meaning that it's not only imaging that is useful, it's not only surgery or gynae or family physician or oncology is useful. What we do is usually it's a multidisciplinary approach. We try to look at the patient from all aspects. We try to reach to diagnosis and treatment. So the way how to screen, usually the most famous way is what's known as a triple test approach. Triple test is meaning that we use clinical examination and we use mammography and self breast examination, trying to identify breast cancer as early as possible. And as we all know, imaging is considered the key component of triple test. However, whenever you think about screening, you have to think what would be the best way of examining any patient. And this question, meaning that how to tailor the breast examination, is really depends on the age of the patient, and it depends as well on the clinical presentation of these patients. So if we talk about a patient with age 40, below age 40, age 30, below age 30, and then we think about if the patient is coming with specific symptomatic symptoms, for example, focal pain, mass, nipple discharge. All of these factors are extremely important in deciding what should I do next as a physician. So to make it easy, I try to divide it into two parts, looking at it as if the patient is asymptomatic, and if we talk about asymptomatic, then we're talking mainly about screening examination, or symptomatic if the patient is coming with something like breast pain or mass or nipple discharge. And then based on the clinical presentation, you divide the age. Is the patient is below age 40 or she is above age of 40? Why does that make a difference? Because the type of the examination we use is really depending on these two factors, the clinical presentation and the age. So if the patient is completely asymptomatic and she is below age of 40, we don't need to do anything. Breast self-examination and awareness would be probably enough. Lots of people, they are against breast self-examination because they say that there's no, it does not prove that it does increase the cancer detection rate. However, personally, I think breast self-examination is very useful. Above age of 40, we always do screening annual mammogram. And this is when we talk about patient who is asymptomatic. However, if we are talking about a symptomatic patient, for example, patient coming with a dominant mass, nipple discharge, asymmetric thickening of the skin, nodularity, Boudoulange appearance, erythema, scaling, eczema, then the clinical presentation would dominate what kind of examination we'll do. Another important factor is the age of the patient. So sometimes and commonly we see patients younger than 30 coming with a palpable mass, and sometimes we see patient 30 and above coming with a palpable mass. So in these cases, what should I do? So to keep in mind, whenever you have and you are faced with a patient who's younger than age of 30, we always start with an ultrasound examination. Very uncommon that we need to do a mammogram examination in these cases. If we have 30 years or older, most of the time, personally, I prefer that I start with ultrasound plus or minus mammogram. And when I say plus or minus mammogram, it means that it depends on whatever I see on the ultrasound. If I see that on the ultrasound there is a benign looking mass, I wouldn't do anything further. If I see something similar to distortion or something suspicious for speculated lesion, then I would move into ultrasound. So into mammogram, sorry. So keep in mind, when we are dealing with patients younger than 40 years of age, your examination, your preferred examination is always ultrasound, plus or minus mammogram, really depending on whatever you see. You would ask me, okay, if the patient is younger than 30 years and I see something suspicious, would I do mammogram? Yes, of course, you would do mammogram. If you see speculated lesion, you would go ahead and do mammogram. However, you might keep in mind that the mammogram usefulness would be limited a little bit because of the density of the breast, but it's still indicated to do that. If the patient is coming with nipple discharge with no palpable mass, again, the age is very important. Most of the time, as I said, I would start with an ultrasound examination, and from there I would move. If I see an intraductal lesion, if I see a microcalcification, I would go ahead and do mammogram if the patient is older than 40. If the patient is younger than 40, I would do an MRI. And if we go back to NCCN guidelines, if you go to the guidelines that was published in 2015, you would find that they mentioned that you would do ductogram. We don't do ductogram anymore because it's an invasive examination. We have substituted that and we do an MRI examination of the breast for evaluation of nipple discharge. In cases of asymmetric thickening, nodularity, again, depending on the age, below 30, below 40, I would say we always start with ultrasound plus or minus mammogram. If the patient is above 40, you would go ahead and do a mammogram examination. Once you have this okay, once you have decided what kind of examination you are going to do, your next step is reporting the examination that you have done. I just want to point out onto one very important thing. Why did I spend some time on what examination should we do? And why should we think about the age of the patient? I've seen a lot of unnecessary examination and unnecessarily mammograms that have been done in younger patients, and this is something that I would not advise to do. The reason for that is we are exposing our young patients to a radiation that is not needed, and then these examinations or these mammograms are not useful. So just spend a little time before doing the examination. Ask your technician to go and ask what are the clinical presentations, what is the history of the patient, what is the risk of the patient, and based on what you gather of clinical information, you move ahead and you decide what type of examination. So moving from there, I'm gonna spend some time on reporting mammogram. So a very important point that I wanna point is what I always say, and I mention in the first line in any mammogram report, we talk about breast density. And based on the ACR BI-RADS lexicon that was published in 2013, there are 4 types of breast density. There is type 1 breast density that is called almost entirely fatty breast, and then type 2, which has scattered areas of fibroglandular tissue, and then 3, which is heterogeneously dense breast, and then type 4. Why is it important that we talk about breast density? The reason for that is because knowing what type of breast density we're talking about, it would make a hint how sensitive the mammogram is for detection of breast cancer. So the sensitivity of mammogram detection of breast cancer ranges from 40 to 90%. Where did 40% comes from? It comes from the sensitivity in type 3 and type 4 breast density. When you have type 4 breast density, the sensitivity of mammogram in detection of breast cancer drops significantly. And that means that these patients, we might be missing some breast cancer. So I always like to use these images of a sky where you have a very clear sky and you have a cloudy sky, just to give you an idea what's the density of the breast. So when I have a predominantly fatty breast, it is similar to a clear sky. And this is what exactly I tell my patients. It's very easy to look and find any masses in this clear sky, or you can find any bird in this clear sky. However, when you have more clouds in the sky, there might be a bird, there might be a cancer hiding behind these clouds, and I will not be able to detect it. So that's why this is the first point that we always have to describe in any mammographic examination, the type of breast density. And this is just the mammogram representation of the breast density. So this is type 1, this is type A, sorry, with the new lexicon, type B, type C, and type D. If you look to type D, I cannot tell you how many cases that I have done in my career. You look at the mammogram, you absolutely identify no suspicious finding, and then you go ahead and you do your ultrasound and you identify suspicious looking masses hiding behind the breast density. So definitely I would say that the sensitivity of mammogram is reduced when we look at breast densities type C and type D. So what do we report in mammographic reporting? So as I always say, sometimes I report incidental findings as benign calcifications. It's completely up to the radiologist to describe them. Some of the patients, they come and they tell me, we really want you to describe every single thing you see because we're going abroad and we want like a very specific comparison. And most of the time, I really don't describe the benign findings because I think as a physician, as a general surgeon, as a family physician, you don't want to have a very long report. You want to have something that point out to the important points. So it's really up to the radiologist's preferences. I personally don't describe benign findings. And then whenever you see something on the mammogram, I describe the exact location of the finding on the mammogram. I describe it in clock face location. I describe it in the upper outer quadrant, lower outer quadrant, in which quadrant. I describe it as a distance from the nipple because if I will do the ultrasound, I want to know exactly where to look for that findings. And then at the end, this is the second most important point, your level of suspicious of malignancy based on the imaging, which means I will give the final BI-RADS category for the findings. So just to summarize, what would we mention about mammographic reporting? I would always mention recommendation for the management. I would recommend what kind of imaging that this patient should go for. If she needs any future follow-up, when does she need the future follow-up? And I would give definitely the final assessment category using ACR lexicon. So this is just an example of a case that the patient came for screening, and I would give you just a few seconds to look at the mammogram. So looking at the mammogram, you can clearly identify that this patient has a bilateral predominantly fatty breast. It's type A. You can describe it type B, which is okay, which means that it's not a difficult breast. And then if you look carefully, you can identify that she has an area of asymmetry behind the right nipple. So what should I do next? Usually I tell my resident, you do a compression view and then you proceed to the ultrasound. So we did the compression view. And if you look on the compression, you can identify that the area of the asymmetry had persisted. It did not disappear. So this is a genuine finding. This is something that I really need to go ahead and do something about it. So this is what I would describe. So you can see I described bilateral predominantly fatty breast. I said retroareolar asymmetry. It persisted after compression. The appearance is probably benign. I would do a compression view on ultrasound. And then right breast BI-RADS 3. Based on the ultrasound finding, or based on what? So I will proceed before giving any BI-RADS. I would give a BI-RADS 0 on the mammogram. I will go ahead and do the ultrasound. If you look at the ultrasound, you can identify that there is a well-defined, benign-looking lesion seen in the retroareolar area. The size is about 2 centimeters. You can see clearly that it has a little bit of posterior caustic enhancement. And then you can see that there is sort of echogenicity or a surrounding echogenic rim around this lesion. If we put a flaw on this lesion, you can identify significant vascularity on this lesion. So this lesion was initially BI-RADed as BI-RAD 3. If I look at this, I would not probably BI-RAD it as BI-RAD 3. I would probably BI-RADS it as a BI-RADS 4. And there is a reason for the BI-RADS 4 classification of this lesion. If you look carefully, the BI-RAD 3 lesion, it should be as a well-defined, benign-looking lesion with a thin echogenic capsule, which does not exist in this case. So I would call this lesion as a BI-RADS 4A. Based on the imaging, what should I do next? And this is something that I definitely would report in mammogram and ultrasound report. I would say that this patient, she needs vacuum-assisted biopsy of this lesion. The reason for the vacuum-assisted, because this is considered as a complex cystic lesion. Complex cystic lesion means it has some cystic component and it has some solid component, which is vascular. So I'm thinking about intraductal papilloma or papillary carcinoma or something located within the duct, and I have to do biopsy for this lesion. So following that reporting, this is something also you have to know about. So whenever we are describing anything in mammogram, we have to give a final BI-RADS category. So BI-RAD, there are 7 different BI-RADS category that we know. There is 0 from 0 to 6. 0, we give it usually for screening when we need to do additional imaging, such as compression view or ultrasound. And then there is 1 that is completely normal, 2 benign findings, and then BI-RAD 3, BI-RAD 4, BI-RADS 5. The category that I like always to talk about and emphasize is BI-RAD 3 category. The reason for that is because this category is usually misused. It is commonly used in an incorrect way, and lots of people, they just throw up findings in category BI-RAD 3. However, if we go back into the ACR BI-RAD lexicon, if we read about the ultrasound imaging of breast, we know that there is very specific criteria that would fall into BI-RAD 3 category. And it is based on that, we would recommend a short time interval follow-up based on this finding. So talking about it, so patient confusing issues that I want to talk about is patient when they come with a palpable finding and negative mammogram. I want to quickly touch on BI-RAD 0, BI-RAD 3, as I told you, and then BI-RAD 4, A, B, and C. What is the difference between these 3 categories? So when I talk about category 0, and this is something also commonly misused by some of the radiologists, we use it for screening mammography only. If I have a diagnostic mammogram, I don't usually use category 0. So it is usually used for screening. Patient is coming completely asymptomatic. Usually I might ask for a previous imaging for this patient for comparison. So I would call that finding is a BI-RAD 0, or I might see something else and I need further imaging, such as a microcalcification that needs magnification, or a mass that needs further compression, or a focal asymmetry that needs further compression. So keep in mind, BI-RAD 0 is used only for screening mammogram. We move into category 3. What is category 3? So category 3 or BI-RAD 3, it is reserved for cases that are probably benign. Probably benign meaning that it's not indeterminate. It's not that I'm not sure is it benign or malignant. That's not right. Category 3, it means that I'm pretty sure 98% that this lesion is benign and there is only 2% chance of malignancy. Where does the 2% chance of malignancy comes from? The 2% come from that when I see a well-defined benign looking lesion, 2% of the well-defined benign looking lesion, they sometimes turn to be malignant. And this is where I want to pick on the follow-up, on the subsequent follow-up. So what do I usually do when I call a BI-RAD 3? I usually go to the patient, talk to the patient, and I tell them, you have something that looks extremely benign and you will need a 6-month follow-up either by a mammogram or ultrasound. You will need a follow-up for 2 years, consecutive 2 years. We will do 6 months and then another 6 months and then 1 year until we complete 2 years of a follow-up. And if we diagnose that the findings is stable over 2 years, then you will go back into a BI-RADS 3 and you will go back into usual screening mammogram or whatever usual we do for you. When we call category 3, if we follow the BI-RADS lexicon as well, there are 3 options usually should be given to the patient. There are 3 things that we can do to the patient. We can give her the option of follow-up that I talked to about. We can give her the option of a core biopsy or excisional biopsy. And we have to be very transparent whenever we talk to our patients. We have to tell them, these are the 3 options. It's completely up to you. You choose whatever you feel like you are more comfortable with. Most of the time, the patients ask me, Doctora, what do you think? What should we do? And I usually, if I'm really confident that I'm dealing with a BI-RADS 3, I would tell them, I personally think you don't need to do anything further except a follow-up in 6 months. So you can give the patient, help them to decide, but you have to give them the 3 options that are available based on the ACR BI-RADS lexicon. So moving into BI-RADS 4, what is BI-RADS 4? Whenever I call BI-RADS 4 lesion, it means that this lesion needs further investigation using biopsy. However, keep in mind, the BI-RADS 4 is subdivided into 3 categories. It is subdivided into 4A, 4B, and 4C. And the reason for the 4A, 4B, 4C, it's not really for the patient, it's not really for the surgeon or the referring physicians, it's for the radiologist himself or herself. It gives an idea for your personal auditing and research purpose, and it will help the pathologist to help you decide if the finding is what we call concordant with your imaging findings. So whenever I call a lesion as a BI-RADS 4A lesion, it means that this lesion is most likely 98% it is benign. However, it got some features that does not fit the criteria of a BI-RADS 3 lesion. When I call a BI-RADS 4B lesion, it means that 50% this lesion might be benign, 50% this lesion might be malignant. So it means that I really have to decide what do I feel that this lesion is going to be. For example, if I have an architectural distortion and I do the biopsy and the biopsy comes back as a radial scar, I would call it BI-RADS 4B. It is concordant. However, if I see a speculated lesion, a large speculated lesion, and I call it as a suspicious lesion, it comes back as a radial scar, this would be disconcordant, and I would advise that this lesion should come out or I should biopsy the lesion, rebiopsy the lesion. The last category is a BI-RADS 4C. Whenever I call 4C, it's basically very similar to BI-RADS 5. It means that 98% this lesion is going to be malignant. I will not accept any pathological diagnosis other than something suspicious. So if it comes benign, I have to go back and biopsy the lesion or send the patient for rebiopsy or excision. So sometimes I get frequently asked, when do you decide if this is a BI-RADS 4A, 4B, or 4C? So I decide 4A. It really depends on how many atypical features that I see on the ultrasound and mammogram. So when I look at the lesion, for example, on an ultrasound, and I see only one of the margin of this lesion is, for example, microlobulated. So I have one single feature that does not fit the benign lesion, then I would call it BI-RADS 4A. If I look at the lesion and I find that this lesion has microlobulated margin, it has a thick echogenic capsule, it has an obliterated margin, it has an extension into a duct, so it got multiple features that does not fit category 3 lesion, so this means that I would put this lesion into BI-RADS 4B. If the lesion has all the malignant features of speculation, thick echogenic capsule, taller than wider, all the features, then that lesion either it will go into BI-RADS 4C or BI-RADS 5 lesion. So as I said, BI-RADS 4A, it means that there is a very low suspicion of malignancy. However, this lesion, I definitely need to biopsy. If the lesion comes back as a benign, what should I do? So there is nothing in the literature that would say exactly what should I do after the biopsy of a BI-RADS 3 or 4 lesion. But what I usually do is I would do a follow-up either in 6 months or 12 months, depending on how suspicious I was about that lesion. So the lesion will be downgraded from BI-RADS 4 into BI-RADS 3, and then I would say 6 month or 1 year follow-up will be done. BI-RADS 4B, a lesion, as I said, it has an intermediate suspicious of malignancy, and I have to do a careful assessment, and then based on the pathology, I will recommend my follow-up. So this is just another example of a patient came with partially visualized, well-defined isodense mass seen in the retroareolar area. We did the ultrasound evaluation, and you can clearly see again what we call as a complex cystic lesion. In ultrasound, it does have a cystic component. The wall of the lesion or the margins is very well defined. It is macrolobulated. It got posterior caustic enhancement. However, because this lesion is a complex cystic lesion, this would definitely go directly into a BI-RADS 4 category. I would probably call this BI-RADS 4A or BI-RADS 4B, because my first differential diagnosis would be it's either might be as intracystic papillary carcinoma or intracystic papilloma. So BI-RADS 4C, it is a finding of a moderate concern malignancy. However, it's not as classic as 5. I usually feel that 4C and 5, they're very close to each other. And I would definitely, if I get something benign, I would definitely repeat the biopsy. A very important thing that you should keep in mind, guys, whenever you are doing breast imaging, you do what we call a radiology pathology correlation. Please, please, if you do a biopsy for any patient, go back and review the pathology result of that patient and check if the pathology results would be concordant with whatever you were seeing on your imaging. Once I have that and I check that, I usually issue a separate report mentioning that the radiology is concordant with the pathology finding, and I would mention what kind of recommendation I would say. For as I said before, if I'm looking at the BI-RADS 4A lesion and I saw something benign, probably it could turn to be benign, and it turned to be as, for example, a fibroadenoma, I would say that this is concordant with what I saw, and I would refer the patient either for 6 month or 1 year follow-up, even if she's young. If the finding is discordant, I would directly contact the pathologist and I would tell them, were you sure that there is no malignancy? Are you sure that there is no radial scar? And if he tells me that, I would go back and contact the surgeon or the referring physician, and we would decide what should we do next. Should we repeat the biopsy? Should we refer the patient for surgical excision? Moving into breast ultrasound, I am one of the big fans of breast ultrasound. I love breast ultrasound. I found it's an excellent modality for breast imaging. It has its own limitation because of the operator dependent, because of the equipment dependent, and we always need, I don't do an ultrasound for a patient who's 40 or less without looking at the mammogram. And I would really advise each one of you, if the patient has a mammogram, please don't do the ultrasound without looking at the mammogram. Because sometimes if you are in a rush and you do your ultrasound quickly, you might miss findings. You might miss an obvious finding on the mammogram. So always look at your mammogram before doing the ultrasound. And these are really the indications of breast ultrasound. So it is usually good to be done next to mammography. Whenever you have a younger patients, younger than 40 pregnant patients, we always start with ultrasound. Whenever we evaluate a male patient, lots of people, they like to do mammogram. I personally prefer to do ultrasound because it's less painful and it would give me the same information that I would get from the mammogram. It is the best and the easiest way to do your interventional procedures, and it is the least expensive in all of the other modality. And then whenever you have and you want to do a second look ultrasound after MRI, ultrasound is good when you have imaging of breast cancer patients. So this is just an example of a young patient. We had a 21 years patient. She was coming with a palpable breast mass. We did an ultrasound. If you look at the ultrasound, you can clearly identify that there is an oval-shaped lesion. However, it has no thin capsule. It is heterogeneous a little bit. This one, she had another one which is a little bit taller than wider, and she had a third one. So all of these breast lesions, they are not typical of a BI-RADS 3 lesion. We did a biopsy for one of these lesions, and all of these lesions turned to be, unfortunately, metastatic lesion from a gastric cancer. This is just another example for a patient with an extremely dense breast. So unfortunately, I don't have the mammogram that was done before the biopsy, but if you look at the mammogram, it would be very difficult to see that there is an area of architectural distortion. We saw the architectural distortion. We took the patient to an ultrasound. We clearly identified that there is an area of architectural distortion. We did the biopsy for this. It turned to be invasive ductal carcinoma. We put the marker and we went back and we did the mammogram to see the area of the biopsied lesion. Again, if you're looking at a complex cystic lesion, ultrasound-guided vacuum-assisted biopsy is the easiest to be done. So you have a cyst, you have a solid component, you go with ultrasound, you do your interventional procedures. It's very easy. You can finish within 15 to 20 minutes from the time of the patient. Another area for ultrasound is treatment planning of radiation therapy. And whenever you want to check for occult metastasis to the axilla, I find ultrasound is extremely helpful to identify the area of suspicious abnormality in the axillary lymph node. Quick note about elastography. Elastography, it is part of the assessment by ultrasound. It's a software in the ultrasound. It's usually used for assessment of the stiffness of the breast mass. There are two types of elastography. There is what we call a strain elastography and the shear wave elastography. I had the chance to work with both. I personally prefer the shear wave elastography because it is not operator dependent. It's really dependent on the machine, and it would give an actual numbers, exact numbers for the stiffness of the mass. So it would give a better indication about how stiff the mass is. So what is the use, just in a quick point, what is the use of elastography for the use in breast imaging? Elastography does help you in differentiating between lesions that you are not sure, is it a BI-RADS 4A or BI-RADS 3 lesion? So it is that area of the hair that differentiate between, should I follow up that lesion or should I biopsy that lesion? So I commonly use it for these cases. So for example, benign looking lesions like cysts, it would look homogeneous with no stiffness around it. This is just a simple cyst. However, when you look at the lesion like that, if you see lesion is wider than taller, slightly heterogeneous, it has a macrolobulated margins. When you do the elastography for this lesion, you can see how stiff the lesion is. This is definitely malignant. This definitely needs to be biopsied. Again, if you look at this lesion, you're not sure, should I biopsy this lesion or not? If you look at the stiffness, you can see that there are areas, some stiff. The values always gives you an idea that this lesion should be biopsied. So moving into the last part of the lecture, which is digital breast tomosynthesis images. What is the digital breast tomosynthesis do? The breast, it is usually part of the breast mammogram. However, we compress the breast tissue. We take multiple images, as in cases of CT scan, with low dose radiograph exposure, and then it will help us to reduce the summation of overlapping breast tissue, which can mimic breast cancer. So this is how it is done. So usually it depends really on the vendor available on each machine. Sometimes the machine would move quickly in an arc, or sometimes the machine would stop, shoot, and give an image, stop, shoot, and give an image, and so forth. So it really depends on the machine. What are the benefits of tomosynthesis? The big benefits, it really was extremely helpful for all of us in reducing the false positive rate, reducing the recall rate, and there is increase in cancer detection rate. People who did use digital mammography without tomosynthesis can tell you how beneficial is digital breast tomosynthesis. We used to do lots of compression view before for areas of asymmetries because we thought that there is a mass and we thought that there is something suspicious. However, when we started doing digital breast tomosynthesis, we know that there is no more masses there, and it's all summation artifact, and it did help in the recall rate and the false positive rate. Regarding the increase in the cancer detection rate, it did help in the cancer detection rate, and this is just a good example. So if you look at the previous mammogram in this case, you can see that in this case, you can see that this is completely normal. You look at the new mammogram, you can see that there is an area of asymmetry. When I look at the image of digital breast tomosynthesis slide, you can see that there is a tiny area of speculation here, and this was done by ultrasound. When you look at the ultrasound, there is a tiny lesion suspicious. Ultrasound guided biopsy showed invasive ductal carcinoma. So it does really help. If you look at this examination, you might not be able to pick anything. If I look at the mammogram, there is something here. You identify it, you go ahead, look at the tomosynthesis images, you can identify clearly a nodule, and that turned to be a cancer. So there is definite increase in cancer detection rate, 0 to 28%, and there is reduction in the recall rate. Should we use it for everyone? Should we use it only for dense breast? Should I use it for all women, or should I use it as a supplemental test for mammogram? So it has been proven that tomosynthesis is very good. If you look at this mammogram, very difficult to pick because of the density of the breast. If you look at the tomosynthesis, you can see that there is a speculated lesions. Actually, you can see the microcalcifications here better than the 2D mammogram. So digital breast tomosynthesis has been proven to be very good in increasing cancer detection rate in all type of breast density. So it is highest in cases of heterogeneous dense breast, where you get about 11 more cancers picked on digital breast tomosynthesis. However, I've seen that I pick cancer more in fatty breast and extremely dense breast and scattered fibroglandular density. So it's very good and it's very useful. The reduction in recall rate, again, it is very good across all category of the breast density. However, it is highest in type 3 and type 4 breast density, as it is expected. This is just another example. If you look quickly, you might pick something here. There is a nodule. I'm not sure if there is anything. If I show you the next image, you will be extremely surprised how obvious the area of architectural distortion in the left upper outer quadrant. Go back, look at it. It's very difficult to pick on this image. However, on 3D imaging tomosynthesis, very easy to pick. This is just another example. You see the area of distortion much better and architectural distortion. So it does help really. What are the drawbacks of digital breast tomosynthesis? The only thing is the radiation dose that is increased by 2-fold. However, this has been significantly reduced with what we call as a sensitized image. We got that in our hospital. You actually do breast tomosynthesis images, and then the software will extract a 2D images from the 3D images, and with that you get your synthesized 2D images in addition to your tomosynthesis images. So you don't expose the patient into twice the radiation. However, you get the benefits of both the 2D and the 3D images. So I'm again a big fan of digital breast tomosynthesis images. I do it for all of my patients, and I do it on both view CC and through lateral view. If you are concerned about the radiation dose, you probably would keep it for the dense breast because this is the area where it showed the most benefit out of it. However, I personally think it should be done for all patients with very good increasing cancer detection rate and reducing mortality. So just to summarize what I talked about, what imaging should we use? This should be your first question. If you are a radiologist, if you are a technologist and you get a request from the physician, look at it, look at the age, look at the clinical history, go back to your radiologist and be sure that whatever examination we're doing is the best for that patient. Whenever I look at the mammogram, I report the mammogram as we discussed. We mentioned the density, we mentioned the finding, the exact location. A very important part is what is your BI-RADS category and what is your recommendation. Don't leave your referring physicians without recommendation because sometimes some of them, they really don't know what to do for the patient. Whenever you do biopsy for the patients, don't forget to do your radiology pathology correlation. It's extremely important. It would make a difference, especially if it becomes discordant and you don't want to miss a cancer that comes back after a year or two and it's very big. We talked about breast ultrasound indications, the use of ultrasound, and we talked about digital breast tomosynthesis, what are the advantages and what are the drawbacks. Thank you so much. I would be very happy to receive any questions, and these are my contacts. I would be really happy to help anyone if you have any queries about anything. Thank you.
الله يعطيك العافية دكتورة نوف. طبعا أنا بس ما كنت حابب أعرف في البداية لأنه العارف لا يعرف، والدكتورة نوف غنية عن التعريف، الله يعطيها العافية. شكرا، محاضرة جدا قيمة يعني. it was very fruitful, very informative. I liked إنه كل شيء وردي اليوم. وكانت هذه يمكن بداية محاضراتنا في شهر التوعية بسرطان الثدي. حبينا نبدأها دائما بشخص مميز في قامة الدكتورة نوف، وهي غنية عن التعريف. يعني أنا قد ما أشكر وقد ما أمدح يمكن لن أوفيك حقك، ولكن يعني علمك يعلم للآخرين، ودائما تواصلك الفعال وحماسك وتعاونك مع الجميع مشهود له، وشهادتنا فيك مجروحة. أنا حبيت بس أقول كلمة الشكر هذه قبل نبدأ الأسئلة. طبعا البث كان في بث مباشر أيضا على اليوتيوب وقت العرض. حنسجل المحاضرة بإذن الله، هي سجلت actually وحتعرض للإخوان اللي ما قدروا يدخلوا معنا. اعتذار للجميع، إنه كان المفترض يكون الحضور 1000 لأنه عدد المسجلين أكثر بذلك من كثير، ولكن يبدو في مشكلة عند نفس البرنامج حق زوم، ما قدر يعطينا acceptance أكثر من 100. لكن إن شاء الله زي ما قلت لكم هي عرضت مباشر، وكذلك ستعرض على موقع التدريب الإلكتروني الخاص بالإدارة العامة للأشعة للي حاب يشوفه مرة ثانية. اللي عنده أسئلة باسم if you can lead that.
الله يعطيك العافية. شكرا دكتور أحمد. اللي في أحد عنده سؤال ممكن raise hand or we can write it in the chat.
أعطيتهم activation باسم؟
بس raise hand وممكن أفتح المايك على طول يعني.
طيب.
أو إذا حد بيكتب في الشات مثلا بيسأل أي سؤال.
وهذا اللي أنا متوقعه، لأنه ما شاء الله يعني من شرح الدكتورة نوف يمكن ما تعطي مجال لأحد أصلا يسأل. ما شاء الله she answers all the questions while we were in the lecture itself. فيمكن آخر شيء بس أحب أقول للدكتورة شكرا لك، وإن شاء الله هذه بداية لمحاضرات قائمة. نتمنى دائما التعاون اللي عودتينا عليه، والله يعطيك العافية وشكرا لك.
الله يعطيكم العافية وشكرا جزيلا على الدعوة وبالتوفيق. الله يكرمكم إن شاء الله.
شكرا لك.
شكرا لك.
مع السلامة.
في سؤال أخير ممكن ناخذه بس.
خلاص I think we can end.
Okay, thank you. يعطيكم العافية.
شكرا لكم. يعطيكم العافية.
طيب.